Hello everyone, my name is Carla and this is my presentation on timing of intubation in COVID-19 patients. Intubation is the process of inserting an endotracheal tube to assist with breathing. We began the COVID-19 pandemic with early intubations, during which patients would get intubated after showing signs of respiratory failure on a maximum of 6 liters of oxygen support via nasal prongs. As we noticed a great number of deaths, we pivoted to the wait-and-see approach using non-invasive ventilation, such as high-flow nasal cannula and BiPAP, to assist patients with breathing. This too, however, led to complications such as crash intubations and cardiac arrest during intubations. And so this is where I formulated my question using the PICO model. In COVID-19 patients, how does early intubation compared with late intubation affect patient outcomes? Early intubation in this case was intubation which occurred within 24 hours of ICU admission, and late intubation was after 24 hours of ICU admission. 5 peer-reviewed scholarly articles were appraised in terms of validity and reliability, bias, strengths and weaknesses, and applicability to question. One study by Rijab and colleagues found a decrease in mortality in patients who underwent early intubation. The other 4 articles found no significant difference, however, several important factors were highlighted from the articles. These being, early intubation groups were easier to ventilate and had better oxygenation. Early intubation groups had reduced risk of transmission to healthcare workers. Late intubation groups had higher incidence of self-induced lung injury and were difficult to intubate, leading to impaired oxygen exchange. And so to answer my question, the evidence clearly showed that early intubation had better patient outcomes. Next, my goal was to create an intervention to act on these results. As nurses, we know the need for intubation is patient-specific. It's important to look at the patient as a whole, taking into account vitals, blood work, diagnostics, comorbidities, and patient presentation. In the ICU I currently work in, along with several other ICUs in the GTA, we have many new graduate nurses who have not had a great deal of exposure to respiratory distress and patient deterioration. We also lack an intensivist at night, and so it's very much up to the bedside RN to recognize changes in respiratory status and alert the physician. For this reason, I thought an educational session would be useful. The session would be on the 2 important components which were highlighted in my research, PF ratio and patient respiratory effort. The educational session would focus on the need for serial arterial blood gas monitoring in order to track changes in PF ratio and observing for signs of respiratory distress as presented by the patient. The purpose of the educational session would be to ensure nurses are better equipped with the knowledge to recognize signs of respiratory deterioration in order to advocate for the need for early intubation. Evidence-based practice is a cornerstone of modern healthcare. This assignment assisted in bridging the gap between evidence and real life to improve patient care. Thank you for listening to my presentation and have a wonderful day.